Hi, my name is Jonathan Parr, physical therapist and EDS specialist here at Parr PT. And the question of the day is, how do we work with pediatrics who have hypermobility syndromes or EDS? Now, it can be a bit tricky because you have to modify things that you do for an adult, for a kid, but there are many different ways to make those modifications. Because they are pediatrics, we have to first modify our pressure so we can still perform manual techniques related to myofascial releases, myokinesthetics, we can do visceral manipulation, all the things that we would normally provide for an adult, just modified intensity level and modified with pressure. The second thing is how do we format the programs? Now, because we typically give really detailed structured programs to adults that has 6 levels and it's pretty detailed from top to bottom, whereas a child has a certain amount of attention span that they're going to actually be able to use by doing these exercises on a consistent basis. We're trying to increase compliance, not decrease compliance. So what we do is we give maybe 2 to 3 different exercises to make sure that what they're doing is short, very focused on whatever their condition or whatever their problem might be, and then being able to progress quickly through that. Because kids are like sponges, they absorb this information super quick, so it's much easier to give them progressions a lot faster than it would be an adult. So understanding what are you giving them, knowing that once they master those skills, you have to be ready to give them another one to keep on improving that progression until they meet the desired result of whether it's pain, discomfort, stability, strength, whatever that might be. The other part of it is that kids don't necessarily need a ton of manual treatment consistently. So after 2 or 3 sessions, they might only need 2 to 3 weeks in between their sessions in order to build up some of that brain to body connection. As they come back and get more treatment, we give them a new program, they reconnect more. So I think having those gaps and understanding when to provide a program, when to do the manual therapy is very key in treating pediatrics, because it doesn't really necessarily follow the same guidelines that we've seen for adults that need a bit more consistency to break a lot of old habits, a lot of fascial restrictions, that obviously more muscle, more restrictions, kids have less. So this kind of paints a different picture of how you can help treat pediatrics who have hypermobility or EDS, because you can still do very similar things with adults with modifications and different progressions on movements. They can still achieve the desired result of alleviating any sort of pain symptoms and improving strength and stability.